For the last speaker, I would like to invite Professor Dadang Makmun, MD PhD, and Prof. Dadang Makmun will give presentation about oral albumin supplementation in gastrointestinal disorder and the other hypoalbuminemic condition. Please to Professor Dadang Makmun. The time is short. The time presentation is 20 minutes.
Yes. Thank you, Dr. Titong. Our college, ladies and gentlemen, Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh, Bro.
I think this is the last topic of this session, and I would like to talk about the role of oral albumin supplementation in GI diseases and many other hypoalbuminemia conditions. This is the outline of my talk, and we already know that hypoalbuminemia is a common condition among all hospitalized patients, among all critically ill, and especially elderly patients. And of course, in addition to that, several GI diseases can be developed a hypoalbuminemia condition, especially GI malignancies, and some condition with protein losing enteropathy or PLE. And low serum albumin level would be associated with longer hospitalization, and of course will increase short and long-term mortality of the patient. And of course, appropriate albumin correction finally can improve the clinical outcome among patients with hypoalbuminemia condition. What is the underlying mechanism of albuminemia? If you look at this slide, hypoalbuminemia in adults is defined as an intravascular albumin level less than 3.5 gram per deciliter. And albumin has a number of important physiologic functions in the body, including to maintain oncotic pressure, to transport various agents, including fatty acids, bile acid, cholesterol, metal ions, and some drugs. And it could scavenging free antioxidant radicals and also acting as an antioxidant and exerting an antiplatelet effect. And the prevalence of hypoalbuminemia is higher among patients, among hospitalized patients, among critically ill patients, and especially among elderly patients. And Brock et al. In their study show that hypoalbuminemia was found in more than 70% of elderly hospitalized patients. And this is some causes of hypoalbuminemia. The first is impaired albumin synthesis, especially among patients with protein malnutrition and chronic liver disease. And the second is because of increased albumin loss, including among patients with nephrotic syndrome, patients with protein losing enteropathy, and patients with extensive skin burns. And the third is because of rare distribution of protein, especially among patients with hemodilution, patients with ascites, congestive heart failure, and patients with acute and chronic inflammation. And this is the pathophysiology of hypoalbuminemia. We already know that albumin is the most abundant protein component in human serum, and it constitutes around 60% of all serum protein by weight. If you look at the right diagram, in a healthy individual, albumin synthesized in the liver, then into the plasma, then finally goes into the interstitial tissue. And then, on the other hand, in the normal individual, albumin degradation is a very modest loss, and then the degradation of albumin and reduction modest in the liver. But on the right side, in the condition of inflammatory diseases, albumin degradations and reduction high in the liver. So it could be linked with the hypoalbuminemia condition. This is the pathophysiology of hypoalbuminemia. The was because of insufficient dietary protein intake, or maybe among patients with hepatic dysfunction, and maybe albumin released into the bloodstream, or among patients with albuminuria, for example, in patients with nephrotic syndrome, patients with increased capillary leak, patients with dysulosis, such as from skin due to the burns, small bowel due to the occult enteropathy, and then among patients with impaired or overwhelmed lymphatic drainage. So all conditions lead to the hypoalbuminemia condition. If you look at this slide, it is very clear that inflammation increases capillary permeability. It will escape of serum albumin, expansing of interstitial space, and it will increase the distribution volume of albumin. And low serum albumin level is an indicator for the severity of inflammation. And pre-existing inflammation is an important factor interfering with the success of medical and surgical treatment and diminishing the adequacy of the response to trauma and disease and reducing quality of life and longevity. And especially in the patient with critically ill, spontaneous rises or decreases in serum albumin levels and the accompanying shrinking weight loss or increasing weight gain, total body water are valuable indicators, respectively, of recovery or deterioration of health. How about among patients with GI malignancy? We know that tumor hypoxia and local tissue damage could lead to the hypoalbuminemia. And then, among patients with GI malignancy, increase in vascular permeability that induce the albumin flux across the capillary wall towards extravascular compartment, and then systemic release of pro-inflammatory cytokine and growth factor, such as interleukin, TNF, and many more in cytokine. And finally, will dysregulate of albumin synthesis by isolated hepatocytes with increased acute waste of protein and decreased albumin, finally lead to hypoalbuminemia. And then, especially among patients with nutritional and functional decline, in patients with advanced stage of malignancy, surgery and chemotherapy modalities can be worsened the physiologic stress apart from the primary inflammatory condition of cancer itself. So among GI diseases, the causes of hypoalbuminemia, the first is impaired albumin synthesis, the second, increased albumin loss, for example, among patients with protein losing enteropathy, such as Crohn's disease, celiac disease, GI bacterial overgrowth, and redistribution of protein, for example, among patients with acute and chronic inflammation, especially in GI malignancy, in colorectal cancer patient, and gastric cancer. About protein losing enteropathy, if we look at the normal condition, there is less than 10% of the total albumin is lost through the intestine. And among patients with protein losing enteropathy, is a less common cause of hypalbuminemia, which characterized by excessive loss of protein, including albumin, via the GI mucosa. And only less prevalence because of among 2 to 3% among Asian patients with systemic lupus erythematosus, and a study of 24 patients with ileal Crohn's disease in clinical remission all had laboratory evidence of protein losing enteropathy. And the mechanism for patient loss in PLE can be classified into 3 categories. The first would be diseases with mucosa erosion, for example, the Crohn's disease, diseases without mucosa erosion, such as celiac disease, and diseases associated with increased lymphatic pressure. So this is the etiology of protein losing enteropathy: erosive GI diseases, non-erosive GI diseases, and lymphatic congestion or lymphatic obstruction. So our college, here is the epidemiology of worldwide GI malignancies. If you look at this data, bowel malignancies and stomach malignancies is the number 3 and number 5 of the most common cancers in the world. And number 3 and number 4, the most common causes of cancer death worldwide. So GI cancer includes esophageal cancer, gastrointestinal cancer, pancreatibiliary, and colorectal cancer. We can look comparing the developed countries and developing countries. In developed countries, colorectal cancer is the number 1, and in developing countries, gastric cancer is number 1. How about worldwide prevalence of GI cancer? This is the data in 2002. Almost 3.5 million new cancer cases in 2002, and predicted to rise to 8.1 million cases in 2020. And then our study in Cipto Mangunkusumo Hospital, Jakarta, almost 75% of GI malignancy cases was accounted for colorectal cancer. And in Indonesia, our data from the Ministry of Health, nearly 70% of patients with cancer are diagnosed with advanced tumor at the time of diagnosis. And until today, the management of advanced tumor remains a challenging problem for most clinicians in Indonesia. And what is the term of advanced tumor? This term is defined for metastasized and inoperable tumors where they cannot be cured or controlled with the treatment. And among patients with operable GI cancer patients, post-operative adjuvant chemotherapy probably can lead to malnutrition status. And in this condition, nutritional support, especially protein supplementation, could be very beneficial. These are the impact of low albumin serum among patients with GI malignancy. It could higher the mortality, anastomotic complication, and the process of metastasis, and patient has poor survival rate post-surgery, and of course can increase the tumor size. And again, hypalbuminemia and GI malignancy is identified as one of factors that may predict cancer survival rate. Decreasing serum albumin levels may adequately indicate the deterioration of the clinical state, and then hypalbuminemic colon cancer patients show high rate of mortality and morbidity, including anastomotic complication, metastasis, poor survival rate post-surgery, and increase the tumor size. And albumin finally play an important role in the management of GI malignancy. This is a study conducted by Hu et al. Preoperative malnutrition with mild hypoaminemia associated with postoperative mortality and morbidity among patients with colorectal cancer. If you look at this slide, some condition could lead among patients with postoperative colorectal cancer, including stroke, deep vein thrombosis, septic shock, need of transfusion, sepsis, or maybe a patient required to return to the operating room. Another study conducted by Liu et al. This study concluded that postoperative albumin with a cutoff of 14% could be used to recognize patients who have high risk of short-term complication following gastric cancer resection. How about oral albumin supplementation among patients with GI diseases and hypoalbuminemia condition? Oral albumin supplementation is referred to the maintaining serum albumin among patients with diabetes crucial, and the methods of hypoalbuminemia management, including through oral supplementation or parenteral supplementation. Oral more favorable for cancer patients, of course, and then by parenteral supplementation using of human albumin is still controversial for patients with cancer because 80% cases has inappropriate indication of using human albumin. And on the other hand, the use of human albumin is expensive. In Indonesia, maybe one bottle of 100 milliliters of 20% human albumin costs almost 1 million rupiah. So this slide shows us the appropriate and occasionally appropriate indication for the use of human albumin according to SIMPTI. The first among patients with therapeutic plasmapheresis and spontaneous bacterial peritonitis. This is the appropriate condition to be given human albumin. And the next is inappropriate indication for the use of human albumin. The first among patients with albuminemia more than 2.5 gram per deciliter, patient with chronic hypoalbuminemia in the absence of edema or acute hypotension, malnourished patient, patient with wound healing, non-hemorrhagic shock, ascites responsive to diuretic, burns, protein-losing enteropathy and malabsorption, acute or chronic pancreatitis, patient with chronic hemodialysis, cerebral ischemia, acute normovolemic hemodilution in surgery, and ovarian hyperstimulation syndrome. All patients are inappropriate indication for human albumin supplementation. And the third is, what is the source of oral albumin? Of course, mostly from dietary source. Egg white is the most common source to provide albumin requirement orally. And other albumin supplement, the first is albumin capsules, less expensive, and then as effective as human albumin in increasing albumin level. It could be extracted from the snakehead fish, Channa striata, and Channa striata is a carnivorous freshwater fish that has higher nutritional value with superior protein content compared to other fish species. For example, for 100 milliliters of snakehead extract contain protein with albumin being the major fraction, 2.17 gram, as well as essential amino acid. This is the study conducted by Zaji et al. The effect of an oral nutritional supplementation on nutrient status and quality of life among patients with colorectal cancer and post-operative adjuvant chemotherapy, a multi-center prospective randomized control trial. This study concluded that oral nutritional supplementation can improve the body weight and BMI of colorectal cancer patients with nutritional risk receiving post-operative adjuvant chemotherapy. Finally, Mr. Chairman and all participants, let me conclude my talk. The first is hypoalbuminemia is a common problem encountered in hospitalized, critically ill, and elderly patients. And several GI diseases can manifest with hypoalbuminemia, such as GI malignancies, and among patients with protein-losing enteropathy. And low serum albumin in GI malignancy is associated with high risk of mortality, anastomotic complication, metastasis, poor survival rate post-surgery, and increase the tumor size. And finally, maintaining serum albumin in patients with malignancy is crucial. And oral albumin supplementation such as Channa striata or snakehead fish extract is considerably more favorable. Thank you for the attention. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you very much, Professor Dadang Makmun, for your excellent presentation that used for us in the management of patients with hypoalbuminemia.